Good afternoon, everyone, and welcome to another seminar series for the semester. So this is our before last seminar of the semester. We still have next week. I hope to see also as many of you next week as well. For today, we are really very, very happy to welcome back Dr. Maha Aon, who recently completed her PhD in epidemiology at FHS. We're very proud of her and the exceptional work that she's done. And I think it's a wonderful opportunity to share her work with the broader audience here at the FHS seminar. So Dr. Aoun is an Egyptian public health practitioner. She's currently based in Copenhagen. Maha's work focuses on the nexus between public health and human rights. She completed her bachelor's and sciences and master's of health sciences at Johns Hopkins University. Maha has 2 decades experience in international public health with international NGOs and the United Nations. She is a member of the technical review panel of the Global Funds on AIDS, TB, and Malaria, and sits on the Lancet Global Health Journal's International Advisory Board. Maha, the floor is yours.
Thank you so much, Dr. Montez.
Just as a reminder, we're going to have about a 40-minute presentation, and then we're going to open the floor for discussion. For everyone, you can please, I'm going to ask everyone please to mute their microphones while Maha is presenting. And if you want to judge your questions on the chat, we'll be monitoring the chat throughout the session. Thank you. Maha, tafadhali.
Thank you, Dr. Montez. Can you see my slides and can you hear me well?
Yes, yes.
Great. Thank you. And thank you for the very nice introduction. And if you've attended my PhD defense, I apologize in advance. This may sound repetitious, but I'm focusing much less on the technical methodology aspects and more on the findings. So I'll be talking today about self-harm and in low and middle income countries and the example of Morocco. First, I just want to acknowledge my PhD committee, my advisor, Dr. Jaffa, Dr. Sidari, my committee chair, and Dr. Abdelrahim, Dr. Molvik, and Dr. Borshman as members of my committee. I just wanted to say that all this research, actually my entire PhD, started with a real world problem. I was working with a Danish NGO that works on prisons and health in prisons. And we were contacted by the Moroccan prison authorities. This picture is actually from a Moroccan prison because they had seen a spike in their suicide rates. So they wanted us to engage and try to help them to find out why this was happening and to reduce it. I'll get into the details of what we did. It started with a real world problem. I take you to within
Maha, you're cutting. I think we lost you.
Can you hear me now?
Yes, now we can hear you. Thank you.
Okay. Individuals who experience incarceration at any point in their life are disproportionately in poor health, both before, during, and after incarceration. I think we have incarceration is not something that just happens out of nowhere and then people forget about it. It's really one step on a trajectory of deprivation. There are 11.5 million people in prison globally at any point in time, and about 1/3 of them are actually in prison without a judgment, awaiting trial. Excluding the US, which has an outlier, a very high incarceration rate, the top 50 countries with high incarceration rates are low and middle income countries. The propensity to end up in prison is not only determined by a decision to commit a crime. It's not that simple, you know, life happens, everything is good, you commit a crime, you go to prison, and then you're out. It's actually very much affected by social circumstances. There is a phenomenon called the criminalization of poverty, And which means that basically people in prison are much more likely to come from a poor background. And that's because there are laws that basically criminalize poverty. So for example, in 42 African countries, vagrancy is criminalized, which is essentially homelessness. Many countries around the world criminalize the inability to pay fines or to post bail. So if you are poor, you're more likely to end up in prison than if you are rich, holding criminality at null. People with mental health problems are also much more likely to end up in prisons. There's research showing that neurodevelopmental disabilities are higher and associated of incarceration. Health, there's a well-established association between incarceration and poor health. Incarceration is both a marker of poor health because, as I said, the disadvantaged are more likely to end up in prison, but it's also a contributor because the conditions in prisons exacerbate or even initiate health problems. Prisons are often home to syndemics where different health problems cluster and interact. There are many studies showing how different diseases are much more prevalent inside prisons than outside. But also not only infectious diseases like COVID-19 and TB and HIV, but also mental illness. Rates of drug dependence, depression, non-affective psychosis, and different diseases are much higher in prisons than outside. But the suffering doesn't end in prison. It continues after release. Rates of drug overdose, suicide, social reintegration, including employment, are much poorer for people who had experienced prison. So really that quote I showed at the beginning was summarizing this, all these facts about you are at risk before, during, and after incarceration, you're at risk of poor health. Even incarceration of family members is associated with negative health outcomes. So putting people, but basically suicide behavior is higher in prisons than outside, but the data is mostly coming from high-income countries, despite the fact that most people in prison are in low-middle-income countries. So for example, the systematic, the latest, has over 600,000 cases, none of which are from low-middle-income countries. The latest systematic review on suicide incidents actually includes 30 low-middle-income countries, and the reason is because those authors contacted individual prison authorities to get that data. So a huge amount of effort to get those 30 countries still represents only 37% of LMICs globally. The reason we basically put it, the next study, which is the systematic review, is because the Moroccan Prison Authority, when we came to advise them on what to do, we didn't find enough data from low-middle-income country prisons. So we conducted this systematic review and meta-analysis. We were looking at the prevalence and incidence of suicide and self-harm in low-middle-income country carceral settings, custodial settings, so not only prisons, but also police and so forth, and trying to understand the predictive factors. We published the protocol and registered it and so forth. I will not focus so much on methods, but just to say that we were actually looking at 6 different outcomes: death by suicide, suicide attempt, suicide ideation, suicidality, which is a composite score of suicide attempt and ideation, and non-suicidal self-harm act and ideation. I will skip the details and go to the results. We ended up with a lot of studies, actually. We were surprised. It was 137 studies, and most of them were cross-sectional. And here there's a chart showing the countries from which the studies came. The biggest bubble down, the green one, is India, which had 25 studies, followed by China on the left, which had 18, and Turkey on the right, which had 13 studies. Most of the studies were conducted only in prisons, 84 of them, but the rest also included police, jails, juvenile detention. The majority, 70 studies, included both men and women, but it's really, really important to say here that even though studies may have contained both men and women, they had much higher proportions of men. The range was between 69 to 99% of the sample were men. So the results are really very biased towards men. So the first thing is the pooled prevalence of those outcomes. I should say, just as a disclaimer, that there was high heterogeneity, but that is normal in prevalence studies. But there was also the quality of the studies was average, especially the ones on death by suicide. However, they probably overestimated rather than underestimated the suicide, which was found to be 10% overall. I provide here sex disaggregated data where that information is available. Where it's not provided is because it was not available in the studies. I think the key thing with all these numbers is that women were almost always higher than men. The prevalence was almost always higher than men. There's one exception, I believe, in the suicide, overall prevalence of suicide. No, even that was higher. But overall, women had higher prevalence than men. And as you can see, the death by suicide was 10% overall prevalence. Suicide attempt increased among women to almost 19%, and so forth. Then we also pooled the prevalence of predictive factors, risk and protective. I want to say here that there were 165 different risk and protective factors in the studies we included, but only 44 of them featured in more than one study, which means that at the end, we could only study 26 risk factors for only 3 outcomes. That's also because we wanted to make sure to focus on good quality studies, and that's why we only included studies that used adjusted multivariable analysis on general samples. So that's why we only ended up with 26 factors for 3 outcomes. And here I present in the table only those that are statistically significant, again, just to simplify and shorten the presentation. For suicidal ideation, the biggest ones related to poor social support and family history of mental illness, and these increased the odds of suicidal ideation. For suicidality, anxiety and low family income increased the odds of suicidality. And for suicide attempts, recidivism, so having been to prison previously, more than doubled the odds of suicide attempts, and being a woman also more than doubled the odds of suicide attempts. So this is summarized. Hopefully we'll have much more details in the paper, which is still being written. So the key takeaways from this systematic review are that there's an underreporting on women and youth. There's higher heterogeneity of the research questions from those studies, limiting the pooling potential. Overall, there's much lower proportion of death due to suicide compared to high-income countries. We found 10%, whereas in Council of Europe countries, it's 36%. And there's lower prevalence of suicide attempts, again, also than in high-income countries. But there's higher prevalence of self-harm. I thought, for me, that's really interesting, that self-harm was really the behavior, at least statistically, that was significantly higher in low-middle-income country prisons. So how does all this relate to Morocco, going back to our real-world question? Well, like I said, the reason we did this entire study was to be able to support the Moroccan prison authority. So we went back with this information and conducted a second study, a case control, looking at only self-harm, because as I just said, we found that self-harm was statistically much higher than suicide or suicide attempts. So determinants of self-harm in Moroccan prison, it was a case control study that is currently being written for publication. Just as a background, Morocco has a very high incarceration rate, over 100,000 people incarcerated, 75 prisons across the country. More than a third of them are just sitting waiting for trial. And it also has a lot of employees. It's important to note that healthcare, including specialized care, is free in Moroccan prisons, and that the ratio of doctors to patients is higher inside prisons than outside prisons. So generally speaking, a pretty decent healthcare system in Moroccan prisons. Also very important to note is that they have a very, very large mental health burden. Inside Moroccan prisons, there's around 10,000 people receiving psychotropic medication, and most people who come into clinics in Morocco are coming in for mental health issues. The suicide rate is very low. It's 8.7 per 100,000, 8.7 compared to 25 from our systematic review, and compared to 80 in high-income countries. And that's why we chose to focus on self-harm and not suicide. The foundation of the study is this program we have with the Moroccan Prison Authority. The QR code here is if you're interested to read more about this work in Morocco. You can scan it, and there's a site that documents this work. We've published a paper about this previously. I think one of my co-authors is logged in today. And we've been supporting them to write a national policy and build their capacity. But very importantly for this study is we had helped them over the past few years to develop a surveillance system for suicidal behavior and self-harm. And that is the source of the data in the case control study for the cases. So it was a national retrospective group matched case control study. That's frequency matching rather than individual matching. The cases were 748 people who had self-harmed in a prison in 2023. And the source of that data came, as I said, from the surveillance system. We matched them. The aim was to get double the number of controls compared to cases. With people who did not self-harm in prison. And the source of that was much more complicated. It was first the database of the prison system where they have everybody who's entered prison, and we extracted the data for 2023 and extracted some of the demographic variables from there. And then we reached out to the prisons where cases had occurred for the matching, both to the security departments and the health departments and the social services department. And I just stress this to demonstrate how difficult it is to conduct studies in low middle income country prisons, even in prisons as developed as the Moroccan ones. It really is quite some work to get this data. So the results, the interesting stuff. Well, most of the people who, for the cases, the 748, most of the people who self-harmed were male. They were adults and they had basic education. Most were either unemployed or in the trade and service industry. 64% had been in prison before, and 60% had a final sentence. 78% had been consuming drugs prior to coming into prison, mostly hashish or alcohol, but 35% were consuming hallucinatory pills. I'll come back to that because we found something interesting related to those pills. In terms of visits, 80% were getting visits from family, but not from lawyers or anyone else. They were regular for almost half of the cases. 70% received regular calls. More than half were participating in cultural activities. The grand majority were not engaged in any training or education, and 65% of the cases were on psychotropic medication. Still on the cases, the rate of self-harm was higher, slightly higher for women than men, but much higher for juveniles, that's basically under the age of 21, than adults. So the rate was 6,550 per 100,000 for juveniles, compared to just 657 for adults. Most had self-harmed before. It was not their first time to self-harm, mostly by cutting. And we found that the rates peaked around national holidays like Eid holiday, for example. We also split it by the employee shifts, day shift, evening shift, or night shift, and found that most self-harm cases were occurring during the day when there were outside activities and you know, there was more access. When we looked at the risk factors and the determinants, basically, we found that self-harm is associated with a network of interrelated factors, both at the individual and institution level. This is in line with the systematic review that we did, but also with global literature. And then I'm going to take each one of these separately. In the multivariable regression results, we found that the results changed depending on if we were only looking at one predictor or if we were bringing in different predictors for the multivariable. But also when we applied clustering or did not apply it. I'll come into that in a minute, but just to say that the prison regime was very, very important in determining if people were going to self-harm or not. So this is the results of the regression, the adjusted odds ratios with clustering, confidence intervals, and p-values. I'm not going to dwell on this, but just to say that what was significant were whether people were having regular visits, whether they were having regular calls, whether they were on psychotropic medication, what type of drug they were taking, if they had been to prison before, if they were juveniles, and their employment sectors. I know you didn't look at the numbers, but that's intentional because I'll come back to it. So the key findings are that the self-harm rate in Morocco prisons is substantially lower than what we found in the systematic review. It's 0.73%, whereas in other LMICs it's 23%. And it's also lower than in high-income countries, which is 3.8%. Self-harm rates are higher for women than men. This is similar to high-income countries. Juveniles have 7 times the odds of self-harm compared to adults, which is similar to high-income countries. And there's a preference for daytime self-harm, 71% of cases. And that may indicate a desire for the self-harm to be noticed, because that's where there's more staff and there's more interaction. And like I said, it peaked around the national holidays, and that may be because people were yearning contact with the outside world. They really felt that separation more around the national holiday. In terms of risk factors, so for mental health, in general, mental health obviously was a risk factor, which again is in line with the systematic review, where we found that family history of mental illness tripled the odds of suicidal ideation. Here we find that people prescribed psychotropic medications had 12 times the odds of self-harm. People who were specifically taking hallucinatory pills, which is likely a clonazepam and benzodiazepine, have 38 times the odds of self-harm. So there's something about people who take those hallucinatory pills that would be really interesting to dig in further compared to taking other drugs. People who consume illicit drugs, that's before incarceration, had 6 times the odds of self-harm. And again, that is very similar to the systematic review findings. In terms of recidivism, having been to prison before, it doubled the odds of self-harm, which is in line with both high-income and low-income countries. And then having low socioeconomic status was a risk factor. So unemployment more than tripled the odds of self-harm, and also precarious jobs like day labor, increased the odds of self-harm compared to working in a more stable job like retail or services. This is in line with high-income countries where unemployment doubled the odds of self-harm, but also with our systematic review, which showed that education and low family income increased the odds of suicidality. Again, it comes back to the very first quote I started with about the vulnerability of people who end up in prison. But it wasn't all so straightforward. This quote basically summarized for me a bit of the findings. I first panicked because some of it did not make sense. That's what I'm going to talk about. And then I was appeased a bit by, when I went into it further, by this quote that sometimes the most exciting phrase to hear in science is not Eureka, but that's funny. So visits, we thought they would be a protective factor, and indeed they were. Receiving irregular visits lowered the odds of self-harm by 64% compared to not receiving visits. But regular visits, although they were protective in multivariable regression, once we added the clustering effect to account for the prison, that effect disappeared. So, which means that regular visits were no longer protective, or at least not statistically significant. So that was a bit puzzling for us. The second thing was the phone calls. Regular phone calls actually increased the odds of self-harm. And we went back and double and triple and quadruple checked the data because we really thought contact with the outside world through phone calls would be protective, but in fact, it was a risk factor. And that made us think that qualitative research is needed. If we want to dig below the surface and understand why is it that phone calls have a different effect on people than irregular visits? And why is it what is it about the prison culture that interacts with regular visits to attenuate its effect on people? So what exactly is happening? And I think that statistics are an absolutely powerful tool, but they're not enough to answer all research questions. And I think here is a very good example of where we need qualitative research to really understand. And since then, we've been discussing this with the prison authorities, and they have different theories about this that make a lot of sense. So a word about clustering. So basically, we found that 15% of the propensity for self-harm was due to the prison, just the prison in and of itself. And that's in line with international research. And that proportion increased to 25%. So clustered analysis is basically when you account for the non-independence of observation, which means that if two people are in the same prison, there is something about being in the same prison that you cannot measure. And that's why, compared to being in a different prison, that's why we account for clustering. And the association between participation in cultural activities, for example, changed, and that depended on the prison. So some prisons have excellent cultural activities while others don't. So that doesn't depend on the individual, it really depends more on the prison itself. So a key finding for us is that really, when we're comparing data for prisons, we have to account for that clustering. So going back to the real world, what does all this mean? This systematic review we conducted, this case control study, how is it going to affect the real world? Well, first of all, the systematic review contributed data from the majority world. At the end of the day, even though the majority of literature comes from high-income countries, the majority of the world lives in low middle-income countries, and that's why we need data from there. Suicide is not the leading cause of death as purported. Even though it may be in high-income countries, it is not the case in low middle-income country prisons. And as I said, even if the quality of the included studies is not high, it is likely overestimating suicide rather than underestimating it, which underlines that finding. It also highlighted the importance of self-harm in low middle-income country prisons. Somehow self-harm is a different phenomena in low middle-income country prisons than suicide. It's used differently, it's employed differently than suicide. It's a different behavior. Then the case control study from Morocco generated data that was not available to the prison authority. It was actually them who asked for the study. And it's helping them now to base their actions on their local context. They're now going to be looking into revising their national policy and manual. And also they are very excited to do the qualitative research to dig more into the telephone versus visits. They were actually not as surprised as I was about the telephone calls, and they said that it's more likely that families resort to telephone to deliver bad news about a death, for example, or a legal case or anything, than to wait until they come for a visit. So phones are being used differently. So digging into that further through qualitative research is something that they would like to do. They're also very happy to have used their surveillance system, and they're very happy to share their experience for other MENA countries or other LMIC countries to benefit. That's it. Thank you very much. I believe I have remained within my allotted time.
Thank you so much, Maha. Yes, plenty of time for Q&A. Thank you so much for really very interesting work, and working with a population that's overlooked and I'm sure very difficult to work with in terms of research. So I'm going to open the floor for our participants. If anyone has a question, you can raise your hand and unmute and speak, or you can also jot down your question in the chat. Any questions? I'm going to start with a question while everyone else joins. Oh, no, we have Zuhair. Zuhair has a question. Zuhair, would you like to unmute yourself and ask your question?
Yes. Hi. Can you hear me? Yes.
Yes.
أول شيء يعطيك ألف عافية. As Dr. Rana said, this was a very comprehensive, very informative presentation. I wanted to ask about the kind of ethical considerations of this. You know, what was taken into consideration? What were some dilemmas that you might have faced? How were they handled, approached, etc.?
It's a very important aspect of such research.
Dr. Momtaz, would you want me to respond or wait?
Yes, of course. Yes.
Okay. Thank you, Zuhair, very much. I think just to start, I think a lot of people shy from doing research in prisons because of these ethical questions. And I was at a conference recently where I thought one of the researchers made a really interesting statement, and he said that we are doing an injustice to people in prison by not conducting studies and by making studying with them so overly complicated that it makes it very difficult for us to get findings from them, especially given that these are the most vulnerable of the vulnerable, and we need more research from there. So just to say that I think it is very possible to conduct ethical research in prisons, and I think that we fear it so much that so many of us just don't even try, and I would like to encourage us to take that further and try to do it. First of all, obviously this research had IRB approval. One of the things that made it much easier to conduct is we did not interact directly with anyone in prison. We relied on data collected by the prison authority. And I think there's not only does that make it easier for researchers to obtain ethical approval because we're not interacting directly, but it also increases national ownership. If we empower and support prison staff to collect the data themselves. The prison staff, don't forget, they are also imprisoned most of the day in there with these people. They also have a lot of knowledge about this. And I think the research we did was with the prison staff, and I didn't include all the details, but we did a lot of capacity building for them. And it was them who helped design the study and some of the policies. So I think, first of all, engaging with the prison staff, it will improve the quality, it will improve the ownership, but it will also help with, reducing interaction with individual people in prison. Of course, interacting with individuals in prison is important. So for example, when we move to the qualitative research, we will have to interact individually. But there is a lot that can be done without interacting individually with people in prison. I think that's it. I'm not sure I want to add any more, but once we do it, of course, you will need to have consent, and it becomes much more complicated if we're going to do it with juveniles, because you need to have assent of their parents, and it will be much more sensitive. But I think it can all be done, and there is more and more research being done. I think the main problem, if I'm going to be very blunt, is not the ethical issues. The main problem is the prison authorities themselves. In many countries, especially in the MENA region, the prison authorities will not allow access to their data or to anything. But if you have a prison authority that actually wants to improve the situation, and this is the situation in Morocco, if they want to improve the situation, then you can get ethical access and ethical treatment of the research subjects.
Thank you, Maha. Maha, so I want to ask you, so in terms of what can be done, in terms of interventions, specific interventions that can be done to improve the situation, have you thought maybe of what can really be done specifically that you found that a significant fraction is actually attributed to the prison environment itself? So as a more macro, more at a macro level. So maybe you can have some insights on what can be done.
Absolutely. I think if I showed that little QR code in my presentation, and if you go in there, we documented the work we're doing in Morocco. There is, I mean, as beautiful and perfect as any prison can be, it is at the end of the day a horrible place to be, prison, and to be deprived of your freedom. However, you can make prisons more humane. And in Morocco, there really is a will to do that, in at least at the high level. So, for example, making sure that there are opportunities for people to engage in cultural activities like drawing and art studios, or to engage in meaningful activities, so they're not just wasting away in a room, especially with juveniles not doing anything all day long. That basically kills the soul. So making sure they're engaged in meaningful activities, making sure that when people are in prison, they're imprisoned in the area that is a region not too far from where they come from, so that families can visit them at an affordable in an affordable way. Making sure that the staff understand that the well-being of people in prison will actually help their work. It will make their work easier. Because at the end of the day, of course, the staff see the people in prison, these are criminals. Why should we ensure their well-being? You should care for our well-being. But if we can package it in a way that makes their work easier, we are more likely to reach something. So the amount, for example, I'll give you, it might seem like a very mundane example, but the amount of paperwork that a staff member has to do if self-harm happens is incredible. And these are already overworked staff. There aren't enough prison guards. And so the prison guards were very motivated with reducing self-harm to reduce their workload. I mean, it might sound a bit harsh, but that is the reality. So making sure to motivate prison staff and show them why this even matters is important, and I believe we've done that to a certain extent in Morocco, in addition to different ways of making the prison a more humane place to the extent possible, of course.
Thank you, Maha. We have a question. We have a hand raised. Usama Tawil, would you like please to unmute yourself and ask your question? Go ahead.
Yeah, hi, can you hear me?
Yes. Would you like to introduce yourself, please?
Hi. Yeah, I'm Usama Tawil, previously colleague of Maha in the UN, and also graduate from AUB from way back. So no need to mention the dates. So thank you for, for this online talk series and the ability to participate from others as well. Yeah, I mean, you've already, Ma, you answered the question, and Dr. Rena also raised the issue. So, I mean, in terms of the impact and what the results of this research could be used for. And you said it also started by a willingness from the Moroccan prison authorities themselves to. I just want to ask, you know, it's a bit just to look into the usefulness of such research. If you ever had or in any possibility of discussing that, or has it been raised by any other countries in the Middle East and North Africa? And just, you know, a related issue, is there any, from AUB's point of view or from your point of view as well, Ma, any kind of platform in the Middle East for discussing these issues about prison context and how to reform or improve or deal with such issues? Thanks.
Thank you so much, Osama. I'm really happy you're here. Osama was my first ever boss in my work life. And again, I'm not going to say how long ago. And the first time I ever entered a prison was with Osama, actually. So thank you so much for taking the time to come and for asking. The first part of the question is if there's interest from other prison authorities. We had interest from Tunisia, the Tunisian Prison Authority, to work on health in prisons, and there's also been interest from Jordan to work on health in prisons. Health is a very good entry into the prison life because it is apolitical. It is something that everybody agrees on, regardless of the crime of the person. It's a safe, if you will, way of entering prisons and making them a bit more humane. Normally there's relative independence of healthcare staff. They're normally, though not always, employed by the security system. So I think the health being an entryway is slowly being seen as a good start. However, I think that both for Tunisia and Jordan, there is a will to engage. I don't know from other countries. We have tried in other countries, but it has not been the case. I think in Lebanon, the situation is much more complicated than Morocco in terms of the services available in prison. But we have done work in the past also in Lebanese prisons, so that could also be a potential. But that's in terms of the countries. In terms of a platform, there are a couple. There's purely academic, where there are working groups to look at research in prisons, where there is some MENA participation, but not very strong. And then there is, in terms of human rights, from a platform, but that does not include prison authorities. It's more of NGOs. And they do not have access inside prisons. What they do have access to is people being released from prison, and then they can provide information. So that's more about documentation and care once people are released rather than inside prisons. I agree with you completely. It has to start with the prison authorities. And I think that there is will, definitely from Morocco and potentially from Tunisia and Jordan. There has also been some interest, at least in global platforms, from some of the Gulf countries, like Kuwait, for example, that has also a very advanced data system in their prison. Dr. Montez, I don't know if you want to say anything about AUB or add something.
No, I don't. I really don't know about, and it's not my area of work and expertise. So I'm not very familiar with the research in prison settings here. But I find it fascinating. So I've done, as you know, I do HIV and STI works, and I've worked before on secondary data related to HIV in prisons in the MENA, and the situation is difficult. So I think this kind of work is very, very important. Thank you, Maha. Thank you, Osama. I think Zuhair has a follow-up question.
Yes, hi again. One, I wanted to mention maybe like the UN Office of Drugs and Crimes would be interested in this as well, if that's a potential for like kind of integrating this research on a more global level. Just like a first thought, yeah. And I wanted to ask, in the analysis, did you account for like the different kind of degrees of or types of criminality? So, for example, if someone was incarcerated for like a minor offense versus a violent crime versus political incarceration. So, was this accounted for in any way? Because I assume, correct me if I'm wrong, but I'd assume, especially in the MENA region, there'd be more like quote unquote unjust kind of incarceration, if that has an effect on suicidality at all.
Thank you, Zuhair. The UNODC, yes, of course, we are in touch with them, and they have a small unit on health in prisons, but it's not health really, it's more HIV. But we're very closely in touch with them, and they also work with the Moroccan Prison Authority. We're slowly trying to prod them to be more interested in mental health, but of course there are funding issues. In terms of the crime, so first of all, in the systematic review, there were several studies that looked at crime as a predictor of suicidal behavior. And they did not really find very strong indications. What we did in the case control study in Morocco was not look at the crime itself, even though we have that data, but look at the penal situation. So have they been sentenced or have they not been sentenced? And here again, we did not find that there was a very big statistical predictor. Having said that, I think you are onto an important point. In other research, it's been shown that people who are in prison for sexual crimes, especially where it relates to a minor, do have a much higher rates of victimization, first of all, meaning that they're being beaten up and treated more violently by other prisoners, but also of suicidal behavior. So I think with the except like for that particular crime where it relates to sexual crimes, especially where it relates to minors, that might be a big flag, whereas with others, it's not so much, although of course I agree with you, Zuhair, that the incarceration rate in the MENA and also in Morocco is higher than in many of the high income countries. It's much easier for people to end up in prison than it is in, let's say, Denmark or Sweden.
Thank you. Any other questions? I have one last question if no one has a question. Okay, so Maha, an interesting finding is that suicide is lower than what you observe in other settings, high income settings and other lower income countries. I mean, why is this, you think, the case? Is it something cultural that has to do with, because self-harm was quite high, but suicide. So any thoughts on that as well?
Yes, I have to say that's the part that excited me the most about the systematic review. I think the theory, and I think it's being supported more and more by research. I have two reasons. One is that we have much higher incarceration rates in low middle income country prison. Like I said, it's easier for people to end up in prison. So the population inside prison in low middle income countries is much more heterogeneous. It's much more varied and more representative of the outside community, maybe of the poor community, than high income countries. In high income countries, it's difficult to end up in prison, and you're much more likely to have a mental health illness, a psychiatric illness when you are in prison. So it's a much more not chosen, but highly vulnerable, at least from a mental health perspective, population. So I think that's number one. And suicide tends to be driven more by mental health issues than by social. Of course, social also drives it. So I think that's the number one reason, in my opinion. The second reason is that suicide in our part of the world, my theory, which has yet to be proven, is that it's a very different behavior from self-harm. Self-harm, I think, at least from what I saw in Morocco, is almost a language of protest in prisons. In prisons from our part of the world, where it's very difficult to voice your criticism, where it's very difficult to get your voice heard, people are using their bodies to protest. And I think that this is being found more and more. Even, for example, I was just recently involved in a study in Italy where they were looking at self-harm in prisons in Italy, and they found that almost all the self-harm cases came from Moroccan immigrants. And it kind of reinforces this that self-harm is almost a prison language. And the finding that recidivism increases the odds of self-harm, it's almost like when you come in prison, you learn that language, and then when you come back, you're more likely to self-harm. So I think that's why that suicide was lower and is lower in low middle income country prisons, and I think that's why self-harm is higher.
Thank you so much, Maha, really, for your time and for presenting this very exciting and fascinating work. Really, we are very proud of your work and of you. And you're really an excellent, ambassador for our program. We had lots of students today in the session. I'm sure that you inspired them, and I wish you all the best in your research and in seeing really impact of this research make a difference. For this population. Thank you again, Maha.
Before I go, I just realized that my advisor, Dr. Jaffa, is online. I really want to acknowledge Dr. Jaffa and say hello and thank you.
يعطيكم العافية for this amazing work.
Thank you so much. Thank you, Maha, for this wonderful presentation. And as Dr. Mumtaz mentioned, you made us proud, Anjad, and you are a wonderful ambassador for the program and for the wonderful job that our PhD students are doing. So keep it up.
Thank you so much.
It was a pleasure working with you. Really, really, it was a pleasure working with you, Maha.
Thank you, everyone. Thank you, everyone, for attending. Thank you, Maha, and we hope to see you soon.
Inshallah. Thank you so much.
Bye. Bye.